CataractCoach.com. IOL calculations in the setting of retinal disease. IOL selection and refractive targeting are critical. So let's look at a few cases. How about myopia? So look at this patient. That's an extreme degree of myopia. And you see the big letters there. Do not aim for plano. You can see the customized spectacles that are required to treat such a high degree of myopia. But look at that picture again more carefully. This patient is monocular. The left eye has ptysis. The right eye is his only seeing eye. He has macular disease. Even before having a cataract, the best corrected acuity was 20 out of 50. And he prefers to hold his phone at 16 centimeters from his face. So he wants to be about a -6 post-op, not plano. In the surgery, like I show here, this is a patient who again gets a very special order IOL, a -10 diopter lens. And that's anticipated to make the patient about a -3 to -4 diopters of myopia for a post-op refraction. So extreme myopia, there's an increased risk of detachment or break in the retina. The vitreous will shift. We're going to induce a PVD as we replace that thick cataract with a very thin IOL. And myopic macular disease may limit the vision. Always aim for at least mild myopia and monofocal IOLs only. For diabetes, vascular occlusive disease, look at this scenario. This is an evolving CRVO, and then slowly it ends up resolving. But it never goes back to perfectly normal. So this is the best case scenario in a CRVO patient. And you can see the patient describes this and made the pictures on the right to show what his vision was like. And as the CRVO started to happen, the acuity dropped and he noticed other things in his vision. Here where he got macular edema, and then slowly it resolved. But this image shows what he sees, and it's not a complete resolution back to normal. So certainly diabetes and retinal vascular issues, macular disease may limit the vision, plano or mild myopia, certainly if they start off with mild myopia, and monofocal IOLs only. Don't try to put in an extended depth of focus lens or a trifocal lens or any other kind of light splitting lens. Retinitis pigmentosa. You can see that's the characteristic retinal findings. These patients have a higher risk of cystoid macular edema. And they also have a high risk of capsular phimosis. So in these cases, I like to have a monofocal lens only. I think a 3-piece design may be helpful if you think there'll be future IOL dislocation from that phimosis. And of course, watch them carefully and prophylactically treat with NSAIDs in cataract surgery after a prior vitrectomy. Now looking at this picture, what's unusual? This patient got a white cataract just a week or two after having a pars plana vitrectomy. That's unusual. Look at the A-scan picture. You can see there's a break in the posterior capsule, and there's lens material that's already leaking into the vitreous cavity. So at the pre-op exam at the slit lamp, we can see that this lens capsule is not bulging forward. Actually, it's concave. The nucleus has already fallen into the vitreous cavity. If you're going to do cataract surgery in an eye that's going to retain silicone oil, that has to be done differently. We'll talk about that. We should add power to avoid post-op hyperopia. After routine pars plana vitrectomy, the patient got a gas bubble or fluid in the eye, but not silicone oil. The lens calculations are relatively routine, but you should still add about a half diopter. So after pars plana vitrectomy, when you're doing cataract surgery, add a half diopter since there's no anterior hyaloid face, and that IOL optic may sit a little more posterior in the eye. If you're keeping silicone oil, add at least 4 diopters, maybe even more, to make sure the IOL is not going to give you post-op hyperopia. Monofocal lenses only and a 3-piece design may be helpful.